All right, we're just going to get started in a little bit. I just wanted to introduce myself. My name is Faraz Khan. I'm an interventional radiologist that works with IR centers and working with Loudon Medical Group Orthopedics. We'll be doing a number of these evening webinars for our patients in Loudoun County to help to give a little bit of education in terms of different treatment options that we have available, specifically for joint pain. But just as a brief introduction, I work for a group called IR centers or interventional radiology centers, and we're a group of radiologists kind of all throughout the country that do a number of minimally invasive procedures. So in one realm, we'll work in men's health and work for gentlemen with an enlarged prostate who are having some urinary symptoms. In another case, we'll work in the GI realm with patients that have hemorrhoids and are having some pain, bleeding, and discomfort associated with them. And tonight's focus and my specialty, working in the orthopedic realm and working with patients who have musculoskeletal or joint pain and different treatment options that we have available for that. So we'll let people continue to join in this evening, but just as a little bit of an introduction, attendees' videos and microphones will be off, but feel free to use the chat feature, and I'll try to go through some of the questions that you may have towards the end. If they're individual kind of personal based questions, it's maybe best just for us to have a conversation one-on-one during consultation, but if they're more general questions, I'm more than happy to answer them tonight. Um, so we'll get started a little bit. So like I said, my name is Faraz Khan. I'm an interventional radiologist here at IR centers in Leesburg or Lansdowne. I did my training in pretty much in New York. So I went to medical school in Stony Brook on Long Island. And then after that, I spent about 6 years doing my residency training in interventional and diagnostic radiology at Albany Medical Center. And my specialty's really been working with embolization and performing some of these more minimally invasive procedures to help patients like you that are having pain. I also wanted to introduce my partner who's not joining us tonight, Dr. Rachel Pachowiak. She also works alongside with us here in our Loudon Medical Group Orthopedic Surgery. And we're partners, so we'll work kind of hand in hand performing some of these procedures together. Dr. Pachowiak did her diagnostic radiology training in Morristown Medical Center in New Jersey, and then she performed her fellowship training in interventional radiology in New York City at Mount Sinai Medical Center. She did a lot of her other training in upstate New York and in Buffalo, and she's been pretty rapidly involved and aggressively involved in some of the clinical research that we have for some of the procedures that we'll be talking about tonight. So just as a brief introduction of what is interventional radiology, it's a medical subspecialty of diagnostic radiology, but we take it a little step further. So this is where we use minimally invasive image-guided procedures to both diagnose and treat disease processes through different organ systems, whether that's the joint space, which is what we're talking about tonight, patients who have cancer, or patients that have had a car accident and are maybe bleeding. We're able to diagnose and treat patients using the least invasive techniques, and that helps to minimize risks to you, the patient, and also to help improve health outcomes. And these procedures have less risk, less pain, and less recovery time than some of our open surgical procedures that are available. So tonight's focus will be on arthritis and specifically knee osteoarthritis. What we know is there's a lot of patients here in the US that have arthritis. So about 30 million patients in the US have arthritis. The knee is the most common site that patients report having pain associated with their arthritis. One of the first things that we'll initially try are just over-the-counter medications like Advil or Motrin. But those aren't benign medications. Sometimes they can cause some side effects or upset stomach, for example, and when taken for a long period of time can cause issues such as ulcers. And there's been over 100,000 hospitalizations associated with some of these things such as ulcers or bleeding going on. So they're not benign just to kind of pop Advil like candy. So alongside hospitalizations, there are some reported deaths as well from using NSAIDs or non-steroidal anti-inflammatory drugs to the point where they're causing harm. So like we mentioned, when taken kind of on an empty stomach and for a prolonged period of time, they can certainly affect the lining of the stomach and gastrointestinal tract and weaken it to the point where sometimes it can cause some bleeding and maybe even death. So there's been about 16,000 reported deaths related to NSAID therapy. So while they're readily available and work pretty well, they're not without their adverse events or side effect profile. Along with over-the-counter medications, sometimes we'll try doing intra-articular injections, whether that's a steroid or a hyaluronic acid injection like Synvisc. And more than 4 million knee injections are performed annually in the US. So this is a large patient population that has this problem, and it's something that we need a little bit more different therapies to try to help tailor individual pain. So there are a number of treatment options available. Here are just a couple schematics throughout them. So we've got a total knee arthroplasty or a knee replacement, more commonly known, where a surgeon is able to cut into the knee, help to cut out some of the portions of bone that are either worn down with that cartilage or diseased, and then replace it with this metal implant that goes into both sides of that knee joint, kind of on two different bones, so that you have a little bit more space in between and have some more stability in that joint space. Other procedures include intra-articular injections. So those are medications like the steroids that we talked about over here, or hyaluronic acid injections, where you may have this performed in the office, either by an orthopedic surgeon or our colleagues in family medicine. Your primary care doctors might be able to perform this as well. And then on our screen left is another procedure commonly offered to patients with knee pain called genicular nerve block or nerve ablation. And this is a procedure where we're able to target a few of the nerves that help to supply that knee joint space and help to use high frequency energy or radio frequency energy to try to burn or ablate some of those nerves to destroy and alleviate some of the pain. So there are a number of treatment options available to help with some knee pain. And these are options you can obviously discuss with your surgeon or personal primary care doctor as well as myself if you're CS in consultation. Now, tonight's focus is on genicular artery embolization, or GAE, and it's a minimally invasive procedure where we work with the blood vessels that supply that knee joint and help to take it from an abnormal high that happens in patients with arthritis and help to bring it back down to a normal level. That sounds a little bit odd, so in terms of blocking blood vessels and organs, so we're going to talk a little bit about why this all makes sense. So we know in patients that have arthritis, the synovium, or the outer layer or coating kind of outside the joint space, becomes inflamed. As you wear down on that cartilage, there's some ongoing inflammation that occurs. Your body starts to produce a number of inflammatory signal markers. One of them in particular is called vascular endothelial growth factor, or VEGF. And its job is to make new blood vessels or beef up the blood vessels that you already have. So slowly over time, you start to grow new blood vessels and have an abnormal increased amount of blood flow to that joint space. That process is called angiogenesis. Alongside those blood vessels and other signal markers promote the growth of small sensory nerve fibers, and that leads to some nerve fibers growing near that joint space as well. And altogether, this increased amount of blood flow leads to more inflammation and swelling, which leads to more inflammatory markers. In this cycle, that leads to this really bad cycle of pain where patients have a lot of discomfort. Here's a little schematic looking at the cellular level in terms of what happens. So as we break down that cartilage, a number of these inflammatory signal markers start to produce an inflammatory cascade and promote blood vessel growth as well as some nerve fiber growth, which leads to pain signals. Now, our group has been very involved with some research looking into different procedures and specifically the genicular artery embolization procedure as a treatment for primary osteoarthritis. So in our study that we've seen, we were able to complete this procedure and show that it was both safe and effective for patients. A lot of the times when we're evaluating patients with pain, we need to standardize everyone's pain or be able to kind of reproduce it a little bit. So we use a number of questionnaires to help us along the way. We'll take a set of questions or questionnaires before any sort of intervention as well as after. That way we can kind of keep track of how you're doing as a patient. One of these questionnaires is called the WOMAC score, or the Western Ontario and McMaster University's Osteoarthritis Index, which is a mouthful, but it's a set of questions that helps to kind of take a look at your overall function on a day-to-day basis with that knee pain, what limitations you might have. For example, going up and down stairs, getting in and out of a car, going from a seated position to a standing position, walking around at the grocery store, for example. Another questionnaire that we'll use is the visual analog scale, or a kind of a scale on a 0 through 100 score, and you kind of pick on a score of 0 through 100 where your pain's at. So we'll use those two questionnaires quite often in research, and we kind of help to use those two terms you'll see throughout some research papers that we'll go through to help us see the success rates of some of these procedures. So based on this trial that we had, at the 1 month mark after having a GAE, 100% of the patients had a significant decrease in their pain and overall increased function. So those are the VAS numbers and the WOMAC score there. So decreasing a high number kind of corresponds to increased pain and decreased motion, ability to walk around or have function, and decreasing those numbers leads to more function and less pain. Similarly, at the 6 month mark, there was still a significant amount of decrease in the WOMAC score, as well as the visual analog scale, or that 0 through 100 pain score. So overall, it really showed that long-term, this procedure is safe and effective and provides pain relief. Also noted, at that 6 month mark, about 65% of patients were reporting decreased use of NSAIDs. So that's also great, just kind of going back to what we initially touched upon, where patients will first start on NSAID therapy, but they're not without their side effect profile. Now, we've had additional research studies that have gone on. We've been able to compare the GAE procedure to a sham-controlled procedure where patients that receive the full therapy are compared to patients that maybe just undergo what we call a sham procedure, where you act as if you're doing the procedure, but you don't get the full procedure, just to compare if the procedure really does work or if it's kind of more of a placebo effect. And from this procedure, from this study, we were able to see that indeed the GAE patients that were assigned to the GAE arm of the study reported improved pain scores as well as increased function, whereas the patients that had the sham or didn't receive the therapy did not. One of the things of this procedure was that if you did not receive the procedure, you were able to then get it done a few months later. And those patients that then crossed over and were able to get that therapy had significant decreases in their pain and improvement in their function as well. So this helped to prove that the GAE procedure certainly works. It's not just the placebo effect. Now, it's not just our group that's performing a lot of the research studies to help support GAE. Some of our colleagues at UCLA are also doing a lot of research. So this paper by Dr. Padia and his team took a look at GAE and found that it's a very effective and durable in terms of reducing pain symptoms for patients that have moderate to severe arthritis that's refractory to other therapies such as physical therapy, oral NSAIDs, or intra-articular injections. They also saw that this was an acceptable safety profile, so low risk procedure where there's not many undue risks for the patients. Other studies that we've done to try to take a look to compare GAE were just to take a look at overall number of different procedures for knee pain. So this paper in particular was a meta-analysis where we take a number of different research papers and try to compare to see where everything lays out. So in this paper, we were able to look at GAE, or genicular artery embolization, comparing some of those studies to intra-articular injections, whether that was a steroid or those hyaluronic acid injections, and also radiofrequency ablation, where we're able to kind of target the nerves. And all of these studies really help to show that these procedures are all helpful in reducing pain. They're all a bit variable in terms of maybe how long they'll last, but they all do a pretty good job of helping some with patients with knee pain. Now, let's focus a little bit on you as a patient. Who's a candidate for a GAE? So patients that, like we have mentioned, have failed conservative therapy. What we mean by that is you've failed physical therapy, you've worked with a physical therapist to try to strengthen some of the muscles to help support that knee joint. Sometimes it's pretty hard to do when you have so much pain where you're not able to participate or do as much physical therapy. Other candidates might be patients that have had injections into their knee, whether that was a steroid or an intra-articular hyaluronic acid or gel injection. Others might be where you had maybe that nerve ablation procedure and it just didn't work for you or didn't last as long. Patients that do pretty well with this procedure can pretty much tell me where their pain is the most. So if you're able to use one finger and point to your knee where you have the most amount of pain, those patients do pretty well after this procedure. That pointing to where you have the focal pain is really a good indicator for what we call synovitis, or that thickening and inflammation of that coating of the knee joint. Other patients that respond really well to this procedure are patients that have hemarthrosis or blood collections building up in that knee joint space. These patients sometimes have a lot of swelling in that knee joint where they have to go to the doctor to have fluid pulled out of the knee joint. And doing this procedure works very well for these patients, and it really helps to decrease the amount of blood or stop the blood from reaccumulating into the joint space. And then for the most part, patients with more mild to moderate arthritis respond best to this procedure and have a very long, durable result after the procedure. That's not to say if you have more of the advanced to severe arthritis, you're not a candidate, but that certainly depends on an individual basis that it's good to have a conversation with your physician about, or for one of us to have a conversation with you about during consultation. So during our workup, what patients need before they're ready to see us, a lot of the times we'll get referrals either from your orthopedic surgeon, PA, an NP, one of your doctors, or your primary care doctor as well. And they'll already have a lot of this information for us, so we don't necessarily need to do a lot of pre-op testing for you. Usually we like to have some sort of imaging, so a lot of the time some plain film x-rays are something that we'll start with. That just helps us to see the degree of arthritis that you have and if there's any major bony structural issues that might be the cause of some of the knee pain that you're having. Some patients do have an MRI just from in terms of their workup or in seeing their orthopedic surgeon, and that can give us a little bit more finite detail from soft tissue with ligament tears or meniscus tears that we're maybe able to see. It also gives us an idea of that thickening of the synovium, but it's not necessarily something that's required before you have this procedure. An ultrasound can certainly help, and that's something that we perform when we see you either in consultation or before your procedure. We'll perform an ultrasound of that knee joint and we'll take a look and see if there's any fluid building up into that knee joint. We'll also take a look at the thickening and see if you do have that increased thickening of that knee joint space called synovitis. And then we'll perform a physical examination, of course, really work with you to try to see where you have the maximal amount of pain. Again, those patients do pretty well after this procedure. Other things that are helpful are just to have some routine labs within the last 6 months to a year. A lot of the times patients are sometimes on blood thinners, so we just like to know if there's an increased risk of bleeding, any ongoing infections, or kidney disease, for example. So here's a little schematic or a little cartoon of what happens to these blood vessels while we're doing a procedure. In this little cartoon schematic, you'll see us accessing a blood vessel into the groin. We've certainly done that in the past, but more recently we've been working with the blood vessels at the level of the ankle near the foot. It's a little bit more comfortable for patients to have the procedure done through that approach, as well as an easier recovery period. And we've seen that we've been getting some pretty nice results with that as well. So I'm just gonna go ahead and get this video going. All right, there we go. All right, so in this video, we'll first start off by entering the blood vessel, and then under live x-ray, we're able to navigate into the arteries that supply the knee joint. We'll do an angiogram, which is where we inject contrast dye under live x-ray, and that helps to light up the blood vessels that supply that knee joint. We'll then use another smaller catheter to super select some of these genicular arteries that supply the knee joint and administer medication or small beads to help reduce or restrict some of the blood flow. It takes about an hour for us to do this procedure, and once we're all done, we'll remove all the wires and catheters. And at the groin level, we'll use a small closure device or a small suture to close up the hole. At the level of the foot, we'll hold some manual pressure. From there, you'll be back in our recovery area. So, what are some of the things that we see as a radiologist during your procedure? And how can I tell what I'm doing, what's going on appropriate, when to start, when to stop? So, this slide here is, and the next couple of slides are going to be pretty busy with a lot of these black squiggles everywhere. The image on the left is a little cartoon schematic of some of the blood vessels that we see and treat during this procedure. This one with the arrow is called the descending genicular artery, and it's one of the main arteries that brings blood supply to the inner portion of your knee. So if you're looking down at your knee, it's kind of on the inner thigh aspect, kind of at the level of the knee joint or above. Um, on the screen right, you'll see this big black hollow line there in the middle, as well as these small squiggles that come off of there. This is that angiogram procedure that I mentioned. So once we're in the arteries under live X-ray, we inject some contrast dye, and that helps to light up blood vessels. So these are the blood vessels that supply the leg as well as the knee. The main big blood vessel in the middle, that big one in the middle, brings blood from the heart all the way down to the foot. And then off the sides of these are small little offshoots called arteries, and they help to bring blood flow to different organs. So in the leg, that would be muscle, skin, the joints, ligaments, all that stuff. So my job as a radiologist and in my training is to interpret this tangle of mess here. So I can tell just based on my experience and training which arteries go to bone, which ones go to muscle, and which ones go to that knee joint that need to be treated. Here I can tell that this is the descending genicular artery. This is one that I really need to get into to give you a good treatment. And on the next image right over here, you'll see that we get further in and we're able to treat you. So what is it that I'm able to see? And these are a number of arteries here. So this is another genicular artery called the superior medial genicular artery. And it's another one that brings blood flow towards the inner portion of the knee. What I'm looking for on my x-ray are these smudgy areas. And I'm just going to highlight this a little bit over here. These little smudgy areas here, that's the increased amount of blood flow that I'm seeing. So this finding here, and this is before I've treated you, just shows and confirms what we're talking about tonight. And that's the abnormal increased amount of blood flow. These small little extra blood vessels are a little too much. So there's too much blood flow here. And that's all resulting from that arthritis that's been going on based on what we've talked about. All right, here's another artery kind of on the opposite side of the knee. It's above the kneecap towards the outside portion of the knee that we'll treat as well. And the next series of these just kind of go through a few. This one is the inferomedial genicular artery, and it's below the kneecap towards the inside portion of your knee. And this one becomes pretty important. A lot of times patients do have some pain towards the inside aspect of the knee. That's where a lot of the weight when you're standing upright kind of falls upon with gravity. So this one tends to be one that I really want to treat for patients that have focal pain towards the inside aspect of their knee. And then one of the other ones that we have is the inferolateral one. Again, these are a bunch of squiggles that probably mean nothing, but to us as the radiologist, they kind of jump right out for me to treat. And here's one of the last ones here. Again, this looks like a bunch of just black squiggles everywhere that maybe a 5-year-old drew, but to us, it's really important to interpret these accurately so we know exactly what artery we're going into to provide a safe treatment. We don't want to go into the wrong artery and block off blood supply to your skin, muscles, or bone. That's obviously not going to be helpful to your knee pain and maybe make things worse. So it's really important to work with an experienced and trained interventional radiologist who has a good degree of experience doing this procedure so that you're in good hands. So what are our endpoints? So we briefly kind of touched upon what I'm looking at in the middle of the procedure. So on the image left is what we call a pre-embolization angiogram, or a picture of the blood vessels before I treat you. And again, it's this kind of dark gray smudgy area here and here that's abnormal. This artery is called the superomedial genicular artery, and it brings blood supply to the inner aspect of the knee. The screen to the right over here now is my post-embolization angiogram, which means after I've delivered some medication or particles to reduce or restrict the blood flow, I do another series of images to see how everything looks. You'll see that there's still some blood flow there. And that's what the concept of embolization kind of comes to. Embolization is a medical term that is used to describe restricting or stopping blood flow. It means different things in different procedures. Sometimes we'll use it for patients that are having some acute bleeding going on. And in that circumstance, we want 100% cut off the bleeding. In this circumstance, we're using it a little differently. We're helping to restrict or reduce the blood supply. I don't want to 100% cut off the blood supply to that knee. You do need some healthy blood supply to the knee, obviously, to maintain a good, healthy knee. So what we're doing is taking it from the left, which is an abnormal increased amount of blood flow based on all that inflammation and arthritis that we discussed, over to screen right, where you still have those natural arteries that you're born with, but the small little extra ones that have developed as a result of all the arthritis are no longer present. And that's my goal. That's what I'm trying to see under X-ray and confirm, to take you from the abnormal high down to a normal level. So I wanted to share an example for a patient. And before I get into this individual patient, I do want to just kind of go over what to expect as you as the patient. So we operate out of our office in Lansdowne on Monday through Friday during daytime hours. So we'll pick a day that works best for you. You'll come in and spend about 3 to 4 hours out of your day with us. The procedure itself takes about 1 hour to complete, but we need a little bit of time before and after just to make sure everything runs smoothly. So once you come in, we'll get you changed into a patient gown, place an IV into your arm to give a little bit of light sedation or moderate sedation. We'll then bring you back to our procedure area where we'll do the procedure that I'll go into a little bit of more information about. So this patient was a 57-year-old male who was referred to us by his orthopedic surgeon. He had ongoing knee pain for quite some time and ended up having some surgery called a right hemiarthroplasty, where they were able to help to repair the cartilage between the two bones that make up the knee joint, as well as that kneecap area. And he had that surgery about 10 months ago, but was really having a lot of pain and swelling in his knee afterwards. And he had to go back to his orthopedic surgeon to have a lot of the fluid drawn out because there was so much fluid building up. His pain on physical examination was kind of at the level of the kneecap, but above on both the inside aspect of the knee and the outside aspect of the knee. So he was referred for a genicular artery embolization for two reasons. The first one was the pain that he was having, and the second one was because he was having what we call recurrent or repeat bouts of these effusions where the fluid was building up. Okay. So here's what his pictures looked like during his procedure. So on the image left, this was a image of that angiogram that we discussed where we're injecting that contrast dye. And we're able to see a nice long black hollow tube. That's the artery that brings blood from that heart all the way down to the foot. And then we have a number of these offshoots. So the one that we're able to further or super select is that descending genicular artery called that DGA. And you can see, I'm just going to point out here a little bit that this amount of blood flow here, this smudginess is all extra. This is really an increased amount of blood flow here. So that's too much. What we then did was administer small microscopic medical grade plastic beads. They're inert and they don't interact with anything. What they do is they restrict some of these blood vessels here. We then did another picture and you see that the main artery is nice and open, but these small little offshoots that were bringing extra blood flow are now gone. And that's our goal during this procedure. Now, in the past, we've used these small microspheres to block off or restrict some of the blood flow. More recent research has actually shown the use of what we call a resorbable agent, and that's what we're using nowadays for this procedure. A resorbable agent is a particle that we use that goes into a blood vessel and shuts it down for a finite period of time. So that artery is closed off. Slowly over time, it dissolves back out and the artery opens back up. And research has shown that using what we call a resorbable agent does an equivalent job of using a permanent agent. So we prefer to use that nowadays. So if you're working with us, you'll be working with resorbable agents For the most part, there are still certain examples where we'll use more of the permanent agents, but that's on a case-by-case basis. Okay. On the opposite side, on the outside portion of the knee, you'll see the same thing where you have a little bit of that black smudginess on the pre-embolization angiogram. And after treatment, you'll see that the main artery remains nice and open and healthy, but that extra amounts of smudginess is no longer present. This patient did very well. These procedures are same-day procedures, so there's no overnight stay. You get to go home after the procedure. Things to expect afterwards. So you may have a little bit of a rash overlying your knee for a couple of days. That's very normal and it does go away. You may have some stiffness or soreness in the knee for the first week, and that's also very normal, does go away. We do give a course of 2 medications. The first one is an antibiotic. Because we're puncturing the skin and working with blood vessels, we like to give what we call prophylactic antibiotics to prevent any infections. The second one is a short course of a non-steroidal agent for about a week called Celebrex, and that just helps during that acute phase where you might have some increased stiffness or soreness in that knee. We then follow through with you and check up on you over the next month or so. So this procedure works really well, but it doesn't work overnight. It does take a little bit of time for this all to work. So on average, it takes about 2 to 4 weeks before you notice improvement in your pain. The reason for that is we're kind of rerouting the blood flow or kind of reestablishing some of the new blood flow to this knee. What we're doing is restricting or shutting down some blood flow. And what that does is it decreases the inflammation that we talked about. It also helps to starve off some of those nerve fibers that have developed as a result of your arthritis. So it takes time for some of those nerve fibers to die off. And in our experience and some of the research experiences of our colleagues as well, on average, 2 to 4 weeks is the amount of time it takes before you start to notice an improvement. Here at our center, we'll follow up with you the next day just to make sure you're doing okay, there were no issues overnight, you got all your prescriptions okay, and that you're on the right track. We'll then follow up with you at the 1 month mark to make sure you're on the right track. It can take 2 to 3 months to get the full maximal benefits of this procedure. And so we'll just keep an eye on you, make sure you're on the right track. We'll also have you follow up with your orthopedic surgeon just to regroup and make sure that you guys are both on the same page, or your primary care doctor to make sure that this problem has been addressed or not. From there, this procedure will last about 2 years to help with some of the pain relief. That's what we've seen based on some of our research in patients that have more mild to moderate arthritis that get a good or technical successful embolization procedure. So in terms of success rates, so we kind of have 2 different ways that we consider success. So we have what we call technical success, which means am I, as your interventional radiologist, able to do the procedure and treat the arteries that I want to treat, the number and where they are based on your symptoms and where your pain is. And that's about 95%. So we do a pretty good job of completing this procedure for you. There's always going to be a small population where there's blockages in arteries, where we're not able to treat all the arteries, and that's kind of pretty rare to happen, but certainly something that we kind of go and discuss on an individual basis. And then clinical success rate, which means how do you as the patient do? That's about, and we're kind of measuring this at the 1 month mark, it's about 90%. So a vast majority of patients do pretty well. And we're measuring that success rate based on those 2 questionnaires that we discussed. So that VAS or visual analog scale, where you kind of rate your pain on a score of 0 through 100, as well as the WOMAC score, where we're kind of going through a series of questions to see how your function and your ability is. And we compare the before and after. And in doing so, we've been seeing that about 90% do pretty well. So vast majority of patients do report pain improvement. Now there's still that small percent, like about 10%, where they're non-responders or don't get relief. That's really going to be with any sort of therapy you have, even a knee replacement. We'll have, some patients do still have pain afterwards. So that's with any sort of therapy that you might have. So that was a little bit about the procedure. Obviously, we'll have more individual-based questions as needed, but I wanted to take a little bit of time to answer any questions that we might have. So I know we've got a number of attendees that have joined tonight, but if anyone does have any questions, feel free to type them out into the chat box and we can certainly answer any there. But otherwise, if you are interested in learning more about the procedure, or if you'd like to have a consultation either with myself or Dr. Pachowiak, feel free to reach out to our telephone number here at 571-577-8920. We also have our email address here. It's lmg2@ircenters.com. For your reference, here's a little QR code over here, so you can use your phone and the camera function to take a picture of that, or just take a look, and it should insert a link to the Google address for our center as well. Now, GAE, or genicular artery embolization, isn't the only procedure that we offer. So in the future, we'll be having some more webinars or kind of these types of events where we'll be talking about other procedures that we have available. Just for some reference, some of the other procedures that we perform are for arthritis or for additional inflammatory processes in other joint spaces. So right now we're targeting the hip joint as well as the shoulder for frozen shoulder. But we're also working with patients that have plantar fasciitis as well. So if any of those are of interest or something that you want to learn more about, feel free to reach out to our center and we're more than happy to send some more information your way. But I'll open it up to the audience here. If you guys have any questions in the chat, I'm more than happy to go over some of them now. A couple of common things that will come up are, this procedure sounds great, but does my insurance cover it? It's a very common question. And one of the things that our team does after we have a consultation is that we'll submit all of the codes that we're anticipating for this procedure to your insurance company through what's called a pre-authorization. So we won't proceed forward with any sort of procedure until we get the okay ahead from your insurance company. On average, it takes about 10 days to get a response from your insurance company, but we have a really good team that's able to submit everything on your behalf. Our team's really good at helping to appeal any denials or working with your insurance company to provide some of the research that shows that this procedure works really well. I will say though, a lot of the private pay insurance companies are seeing that this procedure works just based on more and more data coming out via research. Medicare will also cover this procedure as well, so there's no issues from that standpoint. Other things some patients sometimes ask me are, if I have this procedure done and it lasts a couple of years, what do I do in 2 years? Do I have a knee replacement? What do I do? So one of the benefits of this procedure is that you can have it repeated. So after that 2-year mark, if you're starting to have residual or recurrence of your pain like how you did before, it can be repeated. Over time, what happens is that bone on bone or that cartilage wearing down is still present and your body is still making those inflammatory signal markers. So slowly over time, you will regrow some of those blood vessels and come back to that increased amount of blood flow. So that's why there is a little bit of that time limit on how long this will last you. But we're able to go back into those arteries and treat them again and kind of bring them back down to a normal level. I like to kind of think of it almost like your lawn. So let's say, it's a hot, rainy summer and you go on vacation and you forget to mow your lawn for a couple of weeks and you come back and it's overgrown and it's kind of crazy. That's what I think kind of the increased amount of blood flow is in patients with arthritis. And with the GAE procedure, what we're doing is we're mowing back that lawn down to kind of a normal level. We're not really taking out the sod or 100% shutting down the blood flow, but we're really just taking it from that abnormal high down to a normal level. Okay. All right. Well, I don't think there's any other questions here, but I wanted to thank everyone for spending some of their, evening time with us tonight, and looking forward to maybe speaking to some of you in consultation. Feel free to reach out if you have any questions via the number or email, and we're more than happy to have chats. All right. Thanks so much, everyone, and feel free to either hang out if you have questions or head out for the night.